effective in controlling the post-meal plasma glucose, and what are the targets for the post-meal glycemic control. As we see, the first question here, is there an evidence that the post-meal hyperglycemia is harmful? We have got the level 1 evidence now that the post-meal and post-challenge hyperglycemia are independent risk factors for macrovascular disease. As well, post-meal hyperglycemia is associated with increased risk of retinopathy. Post-meal hyperglycemia is associated with increased carotid intimal media thickness. Post-meal hyperglycemia causes oxidative stress, inflammation, and endothelial dysfunction. It is associated with decreased myocardial blood volume and myocardial blood flow, and it is also associated with increased risk of cancer even. And post-meal hyperglycemia is associated with impaired cognitive in elderly people with type 2 diabetes. So the first one is the level 1 evidence, and the rest of them are level 2 evidence, which has been analyzed and statistically calculated in terms of the significance when comparing to fasting hyperglycemia. As you can see, the basal hyperglycemia is a component of total daytime hyperglycemia, and whatever modality of treatment somebody is on that, we still recognize that the mean excursion of the glycemic excursion is very much dependent on our food intake as well as the modality of treatment which we are using. So one may be surprised to learn that the greater responsibility for clinical inertia and suboptimal care in patients with type 2 diabetes lies with healthcare providers, my very first question, than with patients. When it comes to the patients, they keep coming to you every few months, every few weeks, and you are the one who are guiding them through. The healthcare providers tend to overestimate the degree to which they adhere to the treatment guidelines. They wait longer than necessary to see improvements in measures of glycemic control. 2 to 3 months is adequate to detect a change in the A1C, but A1C is still not in control. One has to look into things. Why is it so? And they project their belief about patient acceptance of or adherence to the therapy, however accurate or inaccurate may they be. What it boils down to, that the way the patient keeps coming back to you, and if you are giving them the advice in terms of the negative feedback to the patient, what you say, maybe you are not following the diet. Maybe you are not exercising enough. Maybe you have to take more care of it, as opposed to intervention in terms of enhancing the treatment as per the guidelines which are already there. The second important factor comes in most of us who are practicing, some of you may remember my question about that what we usually follow when the patient comes to the clinic. He comes to the clinic with a fasting plasma blood glucose. Right? That has been traditional, and every 3 months he comes with an A1C, but not a postprandial plasma glucose. And if you believe that both are equally important, if you rely on the fasting plasma glucose alone, and the patient has been started as a first-line intervention on the basal insulin alone, so what will you see? You will see the patient is on basal insulin along with oral agents. He comes back in the morning with a fasting blood glucose, which is normal, but your A1C is still far away from the target. And you cannot increase the basal dose anymore. So unless you identify the problem and then counsel and educate your patient that all I need are all 3 readings. I need what is your target A1C, how much far away from it is, what is your fasting plasma glucose target, and is it achievable or not? And the next question is, how many of us ask, I want to know your postprandial plasma glucose as well? In our usual standard practice, even if you happen to be a very good doctor and your patient is very good as well, what postprandial plasma glucose would he bring to your clinic? Is it the one after dinner? Or after breakfast? Or after lunch? Right? The normal clinical situation is the patient is on oral agents, usually a sulfonylurea and metformin combination. What time does he take those medications? In the morning before breakfast. At the same time, you give him a basal insulin, which get a good control of fasting plasma glucose. And thereafter, he comes back with a postprandial, which is after breakfast, after a dose of last night's basal insulin, and after a dose of morning sulfonylurea. What do you expect that postprandial to be? Well in control. But the third target which is missing is A1C, which we have to focus on then. So when diabetes is not controlled, whose failure is that? Patients or physicians? How many for patients? How many for physicians? Patient's fault, not physicians? Who is failing? Both? Almost all agree for both? It's in fact beta cell failure. Right? So next time when your patient is not in control, whom would you blame? Beta cell. But think again. It's not always beta cell. Somebody else is doing the fault as well. Anyhow, so what both short and long-term assessment of the glycemic control are necessary, as we all agreed to that. A1C measurement gives you an assessment of the long-term glycemic control. But at the same time, self-monitoring of the blood glucose or home blood glucose monitoring is very, very essential in somebody is poorly controlled with achievement or failure to achieve both fasting, postprandial, and A1C. Any of these things are out of control. You can't wait for ages for that. You have to set a target with the patient as well. Let's wait for 2 months and 3 months, and we'll have to move forward. So it is generally recommended that patients whose glucose is well controlled perform blood glucose monitoring at least once a day, while those whose glucose is not controlled should perform at least twice daily. And that's where is an important message coming out of it. If you're asking the patient to do self-monitoring of blood glucose once a day, what time is it? And traditionally, we have been all taught, and our patients have been educated to come back every few weeks to our clinic with what? Fasting. And we forget the postprandial excursions, which are very detrimental. So the measurement of the postprandial blood glucose levels 2 to 3 hours after a meal may provide useful information for patients whose A1C remains elevated despite a fasting plasma glucose levels at or below target. So these are the indications which we are all aware that the progressive nature of type 2 diabetes require that about 50% of patients with type 2 diabetes for 15 years or longer will need insulin. There are certain characteristics which will identify the patients who need insulin much earlier. And these are the young patients, as Dr. Devendra mentioned, they behave like type 1. The lean patients, again, they may behave like type 1. The higher fasting plasma glucose at diagnosis with lower beta cell result, and up to 15% of such patients, in fact, and investigated, may have positive antibody markers for type 1 diabetes, and you may be just postponing the start of insulin in these patients for no good reasons and for the lack of diagnostic facility available. Initiating therapy with oral agents is a reasonable approach to take with most patients, but there are exceptions even to that, which is concerning about the effect of glucotoxicity and beta cell preservation. So those who come with a hyperglycemia to begin with a blood sugar of more than 250, fasting will require insulin maybe right from the day one. These patients require insulin, even basal bolus insulin therapy to lower the glucose levels. However, clinicians often wait too long to move patients from oral therapy to insulin, but you have to point out here that in the UKPDS study, when it was intensively being treated by a group of good physicians, good patients, and all the resources paid by the controlled study arm, that only 33% of the patients treated with metformin and sulfonylurea had an A1C of less than 7% after 3 years of treatment. So only 1/3 were able to achieve the target which was meant to begin with from the study despite best of the efforts. Now, what is the contribution in terms of the A1C, which is a study which has been shown in quintiles, that what contributes more towards HbA1c? If your HbA1c is high, whether it's more contributed by the fasting plasma glucose or more from the postprandial plasma glucose. And it's very easy to understand that when the whole of the levels throughout the day is high and the blood sugar is maintaining around 250 to 350 the whole day, it's the fasting plasma glucose which is contributing towards it to begin with. And that's the reason when you start treatment and you control their fasting plasma glucose, and if you monitor their A1C, you will see their A1C is coming down. But what happens thereafter is, as you're getting closer to an A1C towards your target, as you can see, from 8.4 downwards, the contribution for the postprandial keeps increasing. So the moment you achieve nearing your target of 8.3 or below, you have to be more concerned about an elevated A1C as more of a representation of the postprandial. And in this situation, if the patient or the physician keep relying on the fasting blood glucose to monitor or adjust the treatment arm, they won't be able to do that. And that's where the situation comes that when you try to achieve a postprandial into the target range in these situations, when their fasting plasma glucose or the pre-meal glucose may be coming towards near normal, and if you start them on the usual insulin regimens, the risk of hypoglycemia increases. And that's where the role of analogs becomes very, very important. One may understand that when the insulin was not discovered, in the very, very early stages in the history of diabetes, people used to say this person has got diabetes and is going to die because we don't have insulin. And thereafter we started relying on the animal insulins, and then the question of allergy and immunity came up. And if somebody was not in good control, we used to say, this person is on non-human, which is an animal insulin. But by the time human insulin was made through the recombinant technology, everybody felt that we have won the war against diabetes and maybe we are done. And all patients, when given the human insulin, will make it to the best of their glycemic control. But we still needed a change. Why were the analogs brought in then? Why do we need? Is analog better or a human insulin better? Right? The logic says human insulin should be better for humans, isn't it? As compared to analogs. But the answer to the query is that the nature injects the human insulin not into the subcutaneous tissue. Physiology injects it into the portal circulation where it goes straight where it is needed. But if you inject the same human insulin into the subcutaneous tissue, it goes to the systemic circulation, and by the time it reaches there, it's too late. And that's why we needed analogs which can work in a different pharmacokinetics and get absorbed as quickly as they should be, reaching along with the food intake. So that's where the point comes in, that if human insulin is available, as well as you have got the analogs available, which one is to be preferred for optimizing the glycemic control in achieving the targets? Besides, we see the concept of Humalog 50 came in for the reason when the studies were done looking at the patient's insulin requirements in those who are on multiple daily injections as well as on those continuous subcutaneous insulin infusions, it was found that their basal dose and the bolus dose requirement were about the same. So initially, we all formulated and worked along with the 70-30 and 25-75, but there was a need for Humalog 50 as well for the reason that some of the patients who are following the usual very critical diet, education, advice, and everything in control, their requirement may well be different in terms of basal and bolus. But you have to adjust it according to the scheduling of the glycemic responses after each meal. So steps for starting insulin therapy in type 2 diabetes. Number one, we have to set a target or goal for the glucose control. We have to tell the patient this is the A1C we are aiming for, which will depend on the individual patient. You may ask that this patient needs a target of 8, 7.5, 7 or 6.5, depending on the comorbids, age, and other functional status of the patient. At the same time, it is very essential because A1C gives you a measure of control over the last few months, but what you are taking the decisions are every day. So the everyday decisions cannot be based entirely on the A1C, so you need both preprandial as well as the postprandial blood sugar measurements. One should use an algorithm to advance the therapy and apply a consistent approach with timelines to reach goal. To determine the appropriate insulin regimen and calculate the starting dose and educate the patient as well as family. When the patient is due to be started on insulin, you yourself are convinced and you have been able to convince your patient as well that this is the time to start insulin. You've got the various options available now. One is the most commonly used is the background insulin when you start with the basal insulin, which could be glargine, determin, or NPH. The next one is the mealtime insulin, in particularly those patients who have got more of a postprandial problem. So you start with rapid-acting insulin analogs or the regular insulin, which is given before each meal, and titrated according to the postprandial control to achieve according to your targets to improve your A1C. And the next one, for the convenience of the patient or those who are following are unwilling to go for the 3 or 4 times insulin regimen, is to go for mixed insulin, which could be 50-50 or 75-25 as per the meal pattern and the carb content of the diet. How does one go for the selection of these various regimens? One can see the background insulin with 2 drugs is useful when the predominant problem is elevated fasting plasma glucose with a stable daytime blood glucose. So from the very day 1, you have to identify these particular patients, whether their problem is predominantly fasting hyperglycemia, and they are very careful about their diet, we are very careful about their exercise plan, and they are controlling their postprandials very well. So this is the situation in which the basal is to be needed. In an Asian culture, particularly at this time, as Dr. Devendra mentioned, that one has to look into what is the postprandial blood glucose after the main meal of the day. In some of the cultures, the main meal of the day is lunchtime. In others, it could be dinner. And if dinner is the main meal, and if you assess that the postprandial glycemic excursion after dinner is high, as well as their basal glucose is high as well, this makes a good case for starting with the pre-dinner Humalog 75-25, because it will take care of both the issues in which the postprandial excursion after the main meal of the day is controlled. At the same time, you are improving the control of the fasting plasma glucose as well. The next is the background and the mealtime insulin plus sensitizers, in which you see there is elevated fasting as well as post-meal. A1C is quite high. This is not the patient for a basal insulin alone, and you want an intensive control. The patient factor here is the patient wants to be more flexible, and there is an erratic schedule. The third one is the premixed insulin plus sensitizers. Again, the same situation, but here the patient does not want to go on to the multiple dose insulin regimens. There is a regular schedule. He eats on time, exercises on time, and monitors on time. Now, what are the advantages, as I mentioned, as opposed to the regular human insulin which we were using? Why the need for insulin analogs came in, and once it's been in there, what are we achieving? The reason for the modification of the human insulin was that it will increase the rate of subcutaneous absorption, so it becomes more physiological. The reduced rate of hypoglycemia, because the effect doesn't last long enough after the glycemic excursion, after the food has gone, the risk of hypoglycemia increases from that onwards. And there is a convenience with increased flexibility, taken with meal, reduced risk of exercise-induced hypoglycemia. There is limited need of snacks in between, and can be used to cover the snacks as well by minimizing the dose as per the snack size. Both basal and rapid-acting prandial insulins are provided in every injection in the Lispro mixtures, and they are very effective and simple for the patients. 2 formulations are available, Mix 25 and Mix 50. Both can be used in clinical practice depending on the prandial basal insulin ratio. Now, with the options available, we will compare what we have been using for years now. Many of us have been using the regular human insulin 70-30 for our usual starting patients, in which the problem is both fasting as well as postprandial glycemic control. And you can see, which was shown by Dr. Devendra, the pharmacokinetics. So the 2 daily insulin Lispro mixtures were twice daily human insulin mixtures, which we are used to, were compared in this study with the non-inferiority hypothesis. And the primary objective was postprandial, but the secondary objective was fasting as well as pre-meal blood glucose, A1C, insulin dose, and hypoglycemia. It was a 6-month open-label randomized 2-period crossover studies. 100 patients were treated with insulin BID for 120 days before